Good afternoon and welcome once again to another episode from Black with Vascular. Today we're here to discuss blue toe syndrome. I had a patient who showed up, had a very tender toe, and ultimately what we found after all of the workup was completed was that this was a small area of cholesterol that was building up in her bloodstream and likely breaking down smaller pieces and sending them downstream and ultimately lodging in the toe. So that is the goal of the mission today, is to sort of break down a complex medical issue into very simple layman's terms so that patients such as yourself, as well as physicians and providers who are taking care of these patients, can easily explain to patients or find a resource to explain to patients exactly what is going on and why they need the procedures or medications that they need. So thanks again for joining us at Black with Vascular. Blue toe syndrome occurs when small pieces of something which is in your bloodstream break off and travel down and get lodged in a very tiny blood vessel, what we call an end artery, somewhere in the body. And usually we call it blue toe syndrome because it's usually apparent in the toes. Very rare to see it in the arms, although it can happen in the fingers. And it can happen essentially in any organ system, as any blood vessel which is large and upstream of a smaller blood vessel downstream as an organ could essentially break off something and lead it downstream towards that end organ. The end organ could be the skin, it could be a kidney, it could be your spleen, your intestines, but if it's in your toes, which is a very common place just because of how your body is shaped, then it will present as a very tender toe that becomes very blue or purple discolored. In darker skinned people such as myself, we will see a more dark purple appearing toe. The key thing to remember about blue toe syndrome is that you have lack of blood flow to an end artery. The smallest blood vessel is now completely blocked and there is no blood flow going. And the question is, what is it blocking it? Is this really something that broke off and travel down, or is there a totally different diagnosis that we have to think about? And this is part of the big challenge for physicians, as many other conditions can similarly present. And then finally, how do we treat it and how do we manage it? And of course, people want to know also the prognosis and the final long-term outcome. So I think we should start with, what is it exactly? Within our bodies and the blood vessels, usually there are three things that can be inside of the blood vessel that is abnormal and should not be there. The first one is plaque, which I kind of describe as like a hard rock-like yellowish substance which builds up slowly along the wall, sort of like a stalagmite or stalactite would build up in a cave. These accretions of years and years of smoking and diabetes and all of the blood vessels and cells migrating into the actual wall, making the wall thicker. First is a little cholesterol streak, a little line in the blood vessel, and then over time it eventually becomes this big plaque or cholesterol buildup in the wall. So that can break off or ulcerate. When it ulcerates, it basically opens up a hole in the top of it, and this area becomes sort of like loose debris and stones that can travel downstream and get stuck into, and I don't know if you can see that, I'm just going to move the camera here, but this area here can ulcerate, and ulcer is this crater-like appearance. If blood is pulsing past this every second, right, and the flow is not laminar, then you can imagine that in this situation, you are actually going to, if you break off a portion of it, then little particles can actually travel downstream. So in any case, so this is plaque. The second thing that could be in the blood vessel is clot. And this became apparent to me, especially during COVID. The entire inflammatory process in the body led to many patients showing up with clot forming along the wall of the blood vessels. This is more of a fresh appearing substance that is soft, just like blood. This is not the same as plaque. This is not necessarily due to smoking and diabetes, although it can be associated also. I should mention that sometimes this can be a mixture of clot and blood that's causing this. So sometimes you have a complex plaque which actually has clot sticking onto it, and it could be a mixture of these separate things. So between plaque, which is more of a cholesterol based thing, and kind of boulder sitting in the stream, and clot, and then a mixture of both, those are the main lesions, what we call problems, that you would associate with someone developing blue toe syndrome. And essentially, you think about it, it's a river, your body's a bloodstream, just like every other river. Particles or rocks within the stream break off ever so often and travel downstream. So if you have an organ like the foot, here's this person's foot, and here's their big toe. As you can see, this is not drawn to scale. Here's the big toe, and eventually imagine that somewhere along the line, the blood vessels become very tiny, about this size, right? And branch and continuously get smaller. Now, if this was a blood vessel, and if this was the only blood vessel leading to the toe, and a piece broke off and traveled downstream, you could see how it could clog this toe, and the entire toe, now lacking any blood supply, becomes blue. Or in this case, we're going to make it purple. So that is the basic understanding of what's happening. And now you ask yourself, how is the patient going to present to the physician, and how will the doctor try to figure out exactly what this is? Well, the first thing that we always do is we do a history, and then we do a physical. You show up to the doctor's office and you need to figure out what exactly are the possible other things that could be causing a problem. So the doctor sees you, you tell them that your toe is blue, it's been hurting for a couple of weeks. They have to now ask you a bunch of questions and try to quickly figure out in 10 minutes, is this blue toe syndrome or is this something totally different? And so what are the things that they would ask? One of the things I would ask is, did you have a recent procedure? This is a common one. A lot of times patients have some sort of procedure, and that procedure could be a heart catheterization, an angiogram, some sort of surgery or procedure recently where a needle or a wire was inserted into an artery, not a vein, into an artery. And during that procedure, that wire may have hit something and dislodged something that was semi-stable within the bloodstream, breaking something off and then allowing something to travel down and cause blue toe syndrome. And of course, depending on where it is in the bloodstream, if it's up in your chest, it could break off and go to your spleen, your kidneys, your blood, your lower extremities, all the way down to your toe, but it could present with a number of different presentations. So people could have leg pain and left-sided flank pain, or underneath the rib cage area pain, which would be suggestive of, even though it's flank pain, if you also have a blue toe, in my opinion, that's blue toe syndrome caused from embolism, or breaking off of something and traveling downstream. That's what embolism means. The word is embolism, and you guys can look that one up. What else? Medications. So people are sometimes on different chemotherapeutic agents for cancer or different medical issues. And either the medical issue itself, the cancer, can cause you to form a clot in your bloodstream because of thickness of the blood because of the cancer and what the cancer is giving off. Or it could be that the medication that you're on to treat the cancer is causing your blood to get thick, or giving you a side effect or reaction such as vasospasm, where the blood vessels get narrowed down. So if it's something like vasospasm, then it's more likely that would happen not just in one single toe, but in multiple vessels. And so that would be one of the clues that the doctor might look at to say, well, this is not really blue toe syndrome as we normally see it. Let me think about something else. And so if you had a blue toe And I've seen this before where one toe is blue on Monday, and that was blue toe syndrome as far as we could concern. But then on Thursday, all the toes were blue and the opposite foot was also blue. Well, that's not really blue toe syndrome anymore. Now we have to think about something else. Even if the following week, the same toe became blue again. It could be that you have Raynaud's syndrome or some other disease process, and we can talk about Raynaud's in a different video, which I'll put a link to. But in general, you can imagine that blue toe syndrome would be usually affecting one single vessel, whereas Raynaud's or any kind of disease process where all of the blood vessels are equally going to be affected by narrowing down or hyperreactivity and hyperconstriction, that would show up with multiple different sites all at once, such as all the toes, all the fingers of the hand, etc. And that's a key distinguishing factor between the two. What else? I would want to know if you have any other medical conditions, such as a blood-borne problem. Like, let's say some people have a disorder like polycythemia vera, where they have excessive red blood cells in their bloodstream, and that causes them issues with circulation, including thickness of the blood, etc. and color changes in their skin. It should not usually cause one single blood vessel, but all of these diseases, and there's a lot of these diseases, including polycythemia vera, as I said, essential thrombocytosis, all these immunologic diseases where your body attacks its own blood cells. There are just so many of them to list here. And this is what's really challenging, is that you came to see a vascular surgeon who operates predominantly on blood vessels, but we don't typically diagnose, at least not in the United States. We do not spend time diagnosing ITP, which is a blood-borne problem, versus essential thrombocytosis or polycythemia vera. Usually we would refer you to a hematologist, a blood medical doctor who specializes in the blood cells, to look into that in more detail. Remember, we operate. You have 15 minutes with us, and we have to try to sort of play the role of all the doctors at the same time. This is what specialty medicine is about. So atrial fib, could it be AFib? Could it be a stroke? Absolutely, could be AFib or a stroke. I mean, and this is not an exhaustive list. I've just put a few things up quickly that I can think of. If a patient has a clot sitting in their heart, and the heart is the main chamber that pumps all the blood through all the arteries, then a clot in the heart could travel down into the toe, and it could cause you to have a blue toe syndrome. Could it be AFib? Yes. And could it cause a stroke in addition to causing blue toe syndrome? Yes. And so when we see a patient with blue toe syndrome, one of the things in my mind always is check the heart to make sure it's not a problem inside of the actual heart, because I'm really worried about the brain as the next place another thing could break off and travel to. So I like to get an echocardiogram in those cases and potentially even see a cardiologist. But before we do all that, I would at least want to listen to the lungs and the heart of the patient to make sure that there's no murmur or nothing else going on. Sometimes people have infected valves. There are many reasons on the inside of that main pump. That pump has multiple chambers and valves, and anything in there can actually cause clots to form and then travel downstream. There's some questions that you ask patients and they say no every single time. And then if you ask them the same question in a different way, they say yes. So I like to ask some of these types of questions. Well, I know that you don't have any medical conditions, but do you see a hematologist? And then they'll say, yes, actually I do see a hematologist. I see a hematologist every month for a problem that I've had for the last 20 years, but it's been quiet. Okay, well, that's very important. You see a blood doctor for something. What is it, and what medications do they have you on, and how do you manage that? The other question is, have you ever had a vascular procedure ever in your entire life? If you've ever had a vascular procedure of any sort, an aneurysm, a stent, a bypass surgery of any sort, you could essentially have a problem here where there's a problem either at the repair site or the original problem is coming back. Everything in your previous history, especially regarding your blood vessels, is important when it comes to this diagnosis. If you've had a history of diabetes or you're a smoker, then that probably, and I probably should have put that as number one, that is probably the first thing we should be finding out from you, because those patients are the ones who over time develop the cholesterol problems in their bloodstream. So the quicker we figure out whether or not you are the type of person who fits into our patient population, the quicker we can get to the diagnosis. And then there's things like infections and COVID and cancer, and could you have formed a clot because your blood is thicker than normal. So we're going to move along now to the next section of the physical exam. And really the most important part of the physical exam outside of the heart is the normal pulse exam. We check the pulse exam and we find that the pulses are actually palpable. If the pulses are palpable, that could be a sign that you have Blue-toe syndrome. Even if the pulses are not palpable, you could still have Blue-toe syndrome. I have seen cases where multiple blood vessels were blocked with either a blockage in the lower leg, which broke off from somewhere else, and then a secondary smaller blockage broke off. So if you can imagine, this is the situation, a big clot here, a piece breaks off and lodges in a vessel right behind the knee. With this here, you no longer can feel a pulse at the level of the foot. But then downstream of that, at the ankle, where you normally would feel a pulse at the dorsalis pedis on top of the foot, or at the posterior tibial, you can no longer feel a pulse. Medical doctors and many students think that Blue-toe syndrome must have palpable pulses like the original description I'm giving, but it's not true. You can have non-palpable pulses. You can have any presentation. This is what makes it so hard. But you have to be always aware of it and really be thinking exactly what is the cause of the Blue-toe syndrome. In this case, a smaller piece has broken off and got lodged into this toe blood vessel right here. And this is why that toe is now blue. Let me just zoom in on that for you so you can see. Main problem, clot that traveled downstream, and even further downstream, another smaller clot has traveled and lodged into the toe, and the toe is now blue. So that is the key factors. And the reason why, again, we listen to the heart is that we really want to make sure that there is not atrial fibrillation, there is a regular heartbeat rhythm, and that there is no murmurs to suggest something like infective endocarditis or a heart valve that you had from a heart surgeon years ago or whenever, and that's now failing and causing clots to travel off. That goes to the same point. If you've had a fever, that's something that you want to tell your doctor during the original history of what took you in to see them. But imagine we're trying to figure all of this out before. So you're watching this video at home right now. I want you to think about all of these things and then go to Google and find additional reasons that I did not put and check them off one by one on your list before you show up to your doctor. When you do show up to the vascular surgeon, who you show up to, or your cardiologist or your primary care doctor, to actually get evaluated for Blue-toe syndrome, you should already have an idea of all of the questions they're going to ask you, and you can just make it easy for them and say, okay, yes, this is going to be this. That means now that we can quickly move along to the next step, which is either treating the correct diagnosis like Raynaud's syndrome or polycythemia vera or whatever it is, or if you have Blue-toe syndrome, we can quickly move along to the higher level discussions such as your surgical procedures and medications, etc. So you've been diagnosed with Blue-toe syndrome and the doctor has decided to treat you. Well, you're in pain and you are concerned about the pain, and you're probably concerned about the risk of losing your digit, and you're probably also concerned about anything else that could be happening and even the procedure that could be coming up. Well, for the most part, I have found that Blue-toe syndrome is more a sign of a long-standing problem that's been there for most of the patients who have atherosclerotic disease and just chronic plaque type disease. That is a sign of something that you probably already knew. You've been smoking for many, many years. You've had diabetes for many, many years. You have all of the different factors involved, getting older, etc. And that has led you to this point. And so You should not be too concerned, except for the fact that you know that now this is where we're at and this is what we can do to make things better. And what we can do is we can eat fruits and vegetables and avoid the processed meats and all the other processed foods that we have. We can quit smoking, we can walk more, and we can take our medications, control our blood pressure, exercise, etc. Those are my kids. So with that said, you've done everything you're supposed to do, and the doctor is telling you, what I think we should do is start you on a medication such as clopidogrel, Plavix, or start you on baby aspirin, or some other type of antiplatelet medication. Or they may even want to start you on a blood thinner, especially if they are suspicious that this is a clot. So don't be surprised if one doctor or one source that you read, Mayo Clinic, Cleveland Clinic, Society of Vascular Surgery, suggests this syndrome should be treated with antiplatelets, but then you end up getting blood thinner like heparin or Coumadin, because the physician is looking at everything and looking at you specifically and trying to come up with the best management and treatment plan for you. So with that said, what else can we do? We can treat the patient with pain control, like we said, and then we can put them on a statin, which is an excellent medication to treat cholesterol, to cut down inflammation, to decrease the chance of clots forming inside of the bloodstream. And then we could do a surgical procedure. And usually I would not do a surgical procedure immediately. I would start with imaging. I would do an ultrasound, and very frequently and more these days, we're getting CAT scans. And I find CAT scans are particularly helpful because one CAT scan can be given up with a diode and can image everything from the thorax right down, your upper chest, all the way down to your toes. And that imaging, although it's more expensive and does have radiation and does expose you to contrast, in my opinion, many times finds a really significant lesion or a really significant problem that can be treated. And if the correct CAT scan is obtained, which is a CT scan angiogram, not just a CT scan with IV contrast, not a CT venogram in this case, but in fact a CT angiogram, then usually, and especially with running off, meaning imaging the blood vessels all the way down as they run down into the toes, then that imaging can give us a full picture and allow the physician the chance to plan your surgery essentially from one single study. It also is relatively quick to get a CAT scan in America, and many parts of the world, it's still reasonably fast if you have it available. So once you've done that, you've found your lesion and you're on your blood thinner and you're doing well, that's essentially it. You're treated. With the exception of the fact that depending on how bad the blood flow is to the toe, if it's just a small lesion in the toe, you may just need conservative management, pain control, and kind of cross your fingers and hope that the blood flow essentially will be enough to heal the wound. If it's multiple lesions, multiple problems, like a blockage behind your knee, that might actually require a totally different treatment. Not just, okay, we're good after just giving you pain control and starting you on a blood thinner, but you may actually need to go in and have that clot removed surgically to restore flow, to allow flow to continue down into your toes and into your foot. And if it's a bigger problem somewhere higher up, and let's say it embolized to your kidney or your spleen, depending on, I think the more proximal the lesion is, the higher up in the bloodstream, the closer it is to the heart, in my opinion, the more worrisome it is, because the higher you're up in the body, the more places it can break off and go to. It can go to your intestines, it can go to your liver, it can go to your kidney, it can go to your spleen. And if it's in the heart itself, then it can even go to your brain, because then it has full access to all of the pathways that blood travels throughout your body. I typically reserve treatment for patients who have this problem, for those who fail to respond to blood thinners or have a very significant looking lesion that is high risk and likely to break off and cause the same problem over again. So for example, if someone has a significant ischemic or lack of blood flow event to their foot or toe, and they have a really calcified lesion that's mixed with some dark and white areas on the CAT scan and suggestive that this area is actually the problem. Let's say it looks something like that. And it's really narrowed, then I would consider putting in a stent in that patient. And if you're in a part of the world where you do not have ability to do a stent, you could do a bypass surgery, or even clean out the blood vessel just by cutting into the blood vessel and removing the problem. But minimally invasive techniques are becoming more and more widespread, and stents are becoming more available. So I think I'll summarize it and wrap it up there and leave it at that. We should probably do in the future something to do with stents and some more procedural based videos, but all of that can come with time. Let me know what you think you want to see more of, and again, like, subscribe if you want to. If you don't, that's fine. Leave a comment at the bottom of the video. That would help me know what is the best next video to make. Give me something related to blood vessels and vascular surgery that you want to know, you want to hear about, and you feel like it's not easily explained through the standard literature that's out there. I'm a board certified vascular surgeon who trained in America, and I'm currently practicing vascular surgery every single day in America. So this is my credentials, and if you want the literature from the actual formal society, then I would recommend you go to the Society of Vascular Surgery website, the SVS website, where they actually have the guidelines that I then study and learn from the masters across the country and across the globe. So thank you again for joining us at Blackwood Vascular, and look forward to seeing you on the next one.